much. Hello, everyone. Nice to meet you all. And good morning. Myself, Divya, a senior lead strategist of global expansion and people experience at Noora Health. A quick on my journey. I was actually since the start exploring the potential of design. As you see, since 2012 is right after my high school is when my journey started. I did my bachelor's in design for strategic branding and visual communication, and I realized throughout my undergrad or throughout my journey, all the clients that I was working with were community based, and some or the other way around, I kept coming back to social impact. This is when I joined Noora Health in 2016 in India, Bangalore, as a visual designer and then a brand lead. While being at Noora and looking at the mission that it was working for, I realized how much I want to be in the health system and how much I want to use my design to make the better health system and strategy. So that is when I decided to come to US, did my masters in design focused on health and a lot of study around user experience in health, and completely focused my design in health field. And in 2022 I rejoined Noora Health as a senior lead strategist. So, yeah, that's my journey. And before I start with any specific topic, I think one story that actually crafted my journey or that made my journey move forward is something that I would like to share with you all. I met a grandfather one morning in the maternal and newborn ward of a government hospital in Maharashtra, India. He was a Sikh man, what we respectfully call a Sardarji in India, probably in his 60s, and sitting quietly at the back of the room, observing the session. We were piloting our caregiver education model, that we also call it as Care Companion Program, CCP, in the state for the first time. After we wrapped up, he walked over to us with tears in his eyes. He said, "Thank you for taking this session. For the first time, I feel hopeful. Hopeful that my son and I can take care of my granddaughter." And that was a little bit of shocking. We were surprised. What does he mean? Is he alone in the family? And then he shared that his daughter in law had passed away during childbirth. Their family had recently migrated for labor work far from their community, with no women left in the household to help care for the newborn. Why the focus on no women left in the household is because traditionally it was always the women who guided this stage of life, especially in India and Asia side. We didn't know what to do, he said. But now, after this session, we know how to hold the baby, how to bathe her, and what warning signs to look for. We feel ready. That moment stays with me. It reminded me of something critical. In many places around the world, healthcare doesn't end when you leave the hospital. It begins there, and often it's not doctors or nurses who are the first responders at home. It's family. It's people like this grandfather. That grandfather's story isn't rare, it's not an case. In many healthcare systems, especially in low resource settings, this is the norm. Most patients don't heal in hospitals, they heal at home. And the people taking care of them, family members, neighbors, spouses, often with no training, no tools, and no one to guide them. Most people assume care happens where doctors are, but in reality, the majority of recovery happens far from the clinic, in homes that are unprepared and unsupported. So, couple of datas here. One of our data says that 2.5 million estimated shortage of healthcare staff to serve over 1.4 billion people in India. That also means these healthcare providers don't get more than 2.5 minutes for these patients and family. And who are these patients? The ones who have got surgery, the ones who have just delivered a baby, or the ones who have gone through cardiac arrest and whatnot, are left with no knowledge or understanding and not having enough time to interact with these healthcare providers. So there is an invisible healthcare system. Let's visualize the patient journey. Notice how long the recovery journey actually happens outside the hospital. Let's look at the journey of a patient, say a woman who's just given birth after 24 to 48 hours in the hospital and she's discharged. From there, the family is suddenly responsible for feeding support, warning signs, newborn care, mother care, and whatnot. And that transition is a cliff. And that's where most systems fail. There is a caregiver burden zone. The data also says globally will like face a shortage of 10 million health workers by 2030, said by WHO. And every year in South Asia, nearly 1.3 million children under 5 die. Far too many of these deaths can be averted through health practices at home, said by UNICEF. This transition period is where gaps in care can have serious consequences, along with readmissions, not recognizing the proper warning signs, and even preventable deaths. Families are left to manage a complex and vulnerable time with very little support. So, who's the first responder? A mother checking her son's fever, a grandfather bottle feeding an infant, a mother in law taking care of her grandchild and daughter in law, a teenager helping a parent with medication. In these moments, the first line of healthcare isn't nurse, it's family, but we rarely design for them. We design beautiful hospitals experience, we design portals, apps, even AI based triage. But what about the moment when a father is holding his newborn up to the light, trying to remember how to check the signs of jaundice and whether the yellow tinge he sees is normal or a reason to panic? This is also a case where we are considering or assuming the father knows what the jaundice is. We have came across in the field where people have shared they have no idea what jaundice is and they felt their child was basically born being yellow. Or when a wife is checking her husband's surgery scar for signs of infection, or in fact, not even knowing if it's an infection and a major warning signs. These are design moments, and this is where UX can and must step in. So, this is our model at Noora Health. What we do, we place patients and their families at the center of healthcare journey. We believe that they can readily transform patients' outcomes. And there are 4 steps of our models. The first one is identifying priority family care practices. We start by understanding what's driving outcomes in a given setting. Then we identify critical, trainable actions family members can take, complementing, not replacing, formal healthcare. This isn't task shifting, it's unlocking the potential of caregiver already at the bedside. So this is where a caregiver and a patient is already in the hospital. So we try to use resources, those are already available around us. We co-create contextual learning material. We work with healthcare workers to develop engaging, easy to understand tools, videos, flip charts, diet models, and more rooted in behavior change science and adult learning principles. All materials are tailored to the context, language, and culture to ensure accessibility and impact. And then the third one is support effective training delivery, which is training the trainers. We equip nurses and staff already embedded in the system to deliver group based caregiving training. Designed with their time constraints in mind, the model streamlines repetitive communication and supports efficiency, not extra burden. And then the fourth is support through tech enabled continued care, which is extend support through tech. Training doesn't stop at discharge. We use mobile tools, WhatsApp messages, voice notes, and more to continue supporting families once they are home, ensuring consistent reinforced care practice. So, where does this take us? What user experience does this model bring in? You'll see I have two comparison, one without CCP. CCP is basically, as I mentioned, Care Companion Program, the model Noora Health carries. And with CCP is once we implement Care Companion Program, what the difference is. So the first one is often we have found families wait anxiously in the waiting areas with very little information and left disengaged from healthcare staff. Mostly the patients are the ones who interact with doctors, and there is this whole waiting area full of all the families and caregivers who are waiting there, being anxious and not knowing how could they help their loved ones. So with Care Companion Program, what we do is families are engaged by healthcare staff and gathered together in a ward, hallways, or waiting rooms. Then families try to catch nurses in a basic scenario without CCP, where who end up answering the same question from bed to bed. As we saw, these nurses and healthcare providers do not have enough time for each patient. So they end up spending very little time and the same message bed to bed, which also end up demotivating nurse and taking away that whole experience of her actually being motivated and passionate about sharing those messages. So what we try to do is we training sessions is delivered. So we bring the training sessions, we train all our nurses and the resources, basically the healthcare providers who are available in the hospital itself. The training session happens for 30 to 60 minutes with all of them all together on skills building with demonstrations and plenty of time for Q&A. And this Q&A also helps with if one patient or a caregiver has a certain question and there was another patient or a few others who have similar, they get to hear the answers all together. Then there is the third scenario where healthcare staff spend very little time with patient families, having just a few minutes before discharge to transfer care. After such a big surgery or delivering a baby and whatnot, they leave hospitals with no knowledge or very less information, and the majority of the time at home while taking care of their loved ones is where they face problems. So, here, as families are able to ask questions in the few minutes before discharge, focusing on their unique situation, the nurses have enough time to answer those unique questions and answers to these patients. Then, last second is families return home confused without CCP, which we have most of the time seen, having been thrust into their roles as caregivers at home without training or specific skills. Whereas over here, families return home confident and supported. Last but not the least, because of these health system that we have seen so far, the readmissions and complications occur, and which they are in the same loop again and again, also if they identify the warning signs on the right time. Otherwise the results are way harder. Whereas with CCP, family receive continued support for home care through our Care Companion Program platform, where they can ask question and get properly redirected to hospitals only if needed. So think about the last time someone in your family was sick. Let's take 15 seconds. Who was the first person to respond? Was it the doctor, or was it you or your family member? And I'm sure most of you have come across the first responder is always the family members or friend or the people really close to you. That's the reality for billions of people. And we, as designers, have a responsibility to recognize that. So, designing for caregivers, let me take you into the field where design isn't about pixels, but about trust, timing, and cultural fit. Back in 2018, we asked a question: could WhatsApp, a tool already in people's hand, become a health companion for caregivers? So we tested a rough prototype in homes, sending simple voice notes and videos about newborn care. It felt experimental. We weren't sure how people would react, but one insight became very clear. People were more willing to engage with familiar, informed tools than any formal health apps. In my initial research phase at Noora Health, during one of my home visit, I met a father whose wife had been discharged from the hospital just a couple of weeks earlier. We asked him how they were managing the baby's care, whether they were using any technology, apps, or tools to support them. So he shared that when unsure about something, he often turns to YouTube to find videos. But more often than not, the videos aren't available in a language he understands. It's not relatable, or he's not sure if the information is even trustworthy. Also, these are the remote areas where a basic clinic or hospital is 40 to 1 hour of a distance. He added that the hospital is too far away to visit easily and they aren't given the doctor's contact details after discharge. So, when we have questions, he said, we have no one to ask except family members or someone experienced in the neighborhood. We tested our WhatsApp prototype with him. We gave him a number to try, and as soon as he gave a missed call, he received a message welcoming him to the service. The message included simple instructions on how to use it and signed him up for home based newborn care. Almost instantly, he received his first message: information about newborn warning signs, all officially approved and associated with the National Health Mission, a source he trusted. He smiled and said, YouTube takes so much time to load because we don't have good internet in our village. But WhatsApp works even on low network. It's so quick to receive and send messages. Curious, he typed in a question and within a few minutes he got a response. And this shows tangible example of how human-centered design, behavior change design, and simple tools like WhatsApp can make a life-saving difference for caregivers. This is today's polished UX of the WhatsApp flow that we use. Today, the service reaches millions. It's simple, accessible, and respectful of people's time, language, and context. This is also something that we started from one village in India to now the entire country, Bangladesh, Indonesia, Nepal, and looking forward to grow more. We didn't invent a new tool, we just designed health into what people were already using. And this service comes with user can select preferred language. They will be tailored message, customized stage based information, rich media, short form videos, visual aids, audios, and then live support that patients and caregivers can engage and ask questions on WhatsApp from 7 a.m. to 9 p.m. all days a week in their preferred language. Now, coming to designing for trust and culture relevance. We met a caregiver who misunderstood a poster because the illustration showed a vegetable that they don't get in their village and didn't have a proper diet. It seemed small, but it made the information feel not for us. We adapted versions of designs for different geographies that shows culturally accurate visuals and information. So familiarity builds trust, trust drives action. Designing for is not enough. You must design with, and that's where co-creation comes in. So at Noora Health, what is co-creation? The most effective way of using design thinking or human-centered design is to design with the people instead of for them. The image you see is from Indonesia. I think once first when we explained our model or what we do and what changes we are supposed to bring, their first question was about like, but how will this be culturally relevant to us? And that is where we did co-creation. And it is a participatory method we use to bring healthcare staff or patients and family caregivers into our brainstorming and feedback process so that we can build a shared understanding of something together. And co creation ensures that we do not make decisions based on our existing knowledge and biases, but are instead learning from and with the people who are or will be actively participating in our program interventions. So, by adapting materials to reflect caregivers' actual environments, we saw a sharp increase in comprehension and confidence. Also, and this need isn't limited to South Asia. In a project with one of the client in the US, I found that even in high resource settings, caregivers lack support after discharge. Different geography, same gap. Caregivers feels lost. UX can and should fill the void. These are just two examples, but they represent a larger shift. UX in healthcare isn't just about digital health, it's about human health. And when we design for the real context of caregiving, we move closer to health equity. With this, to summarize, we have a short video for you all, and then I can take questions. Thank you. With you, I think I'm ready to take questions or comments.
Divya, you done? Thank you so much for that. Can you hear me?
Yes. Also,
Oh,
I'm
perfect.
very happy and willing to connect with each one of you over here. Hopefully, you all have my LinkedIn profile as well and would love to talk more.
Um, just that video you played didn't have any sound. I don't know if you knew
Oh,
that.
I'm so
It's
sorry.
fine. It's fine. We don't. It's fine. So just a few. I had one question, and then there was another one that um, I'm sure you probably read what Missy said. Um, this is from, I'm assuming it's Eugenie. The invisible healthcare system concept is truly great and promising, and it definitely deserves more attention from the UX community, which I totally believe. So thank you for that. Let's just see if we have any questions. So let me start with the first question. So what safeguards technology from becoming a barrier for caregivers with low latency literacy?
Okay. What safeguards prevent technology from becoming a barrier for caregivers with low digital literacy? I think that is where we were looking into something that they are already used to, because any new app, any new another platform that they need to get trained into, unless we take them through training. And plus, as we saw one of the example, it comes with all the factors, is like, do they have a good internet available, do they have a good phone available where they can use those technologies. So when we talk about low resource settings, those are the barriers where it comes from, and that's how we need to look into how technology can grow with how they are growing in their lifestyle. But otherwise, I
Okay,
think as the AI is coming and a lot of new technologies are coming, I think having customized language, customized, cultural relevant information is a must and would hopefully become way easier and smoother. But I think we are still trying to figure out the ways how technology can best support this. But definitely, at home care is something where we rely on the technology, as we know, and the data says as well that healthcare providers are not available with them where they are all the time when they need the most of the recovery time or care when they need it. Yeah.
okay. Um, this is another question you have. Can you share an insight you gained from co-creating with the community? Something you wouldn't have thought of without them.
Oh, yes. This is very interesting because as soon as I read this question or got to know this reminds me of my first initial co creation session with the community, where I was working more on the visuals in terms of understanding what is the visual literacy of the community and if they understand what we have designed. And they get to basically get the message, they receive the message the way we want to deliver the message. And in one of the testing of these elements, there was a sun and the moon. The sun was, of course, the yellow, and then we were talking about UV rays and all, and the moon was, of course, the white moon and the nighttime. But it was so interesting that there was this man who looked at those visuals, and we asked him, what do you get it from it? And he said, the visual of the sun, he said it's the moon, and the visual of the moon, he said it's sun. And we were like, did we misheard it, or what just happened? And then we asked him again, what do you, can you explain, can you elaborate, why do you feel this is sun and the other one is moon? So the white color circle was sun and yellow color circle was moon. He mentioned that in the daytime, when you look in the sky, the sun is too bright, it's white, and you're not able to look at it, and that's why this is sun. And the other one, yellow, being at night when you look at moon, it's yellowish, and there is the cloud in front of it, which make it yellow in color. And that was so interesting, that made us realize that we assume that the learning we have got, the education we have got, is something that how the community will perceive. And when there is a man like him who hasn't gone through the same education or the same knowledge, can perceive it in very different format. And the message for him about UV rays and everything got changed, because he was like, at night this happens and the morning time that happens. So that was one, I would say, co-creation session that definitely made us understand how much vigilant we have to be while making all those visuals. And I have many and many of such informations or stories from co-creation session that has definitely improved our tool. One was this visual thing, and then the others where we actually got, as in one of the image you might have seen, that diet, we made a thali model. Thali is basically a called dish in English, and in Hindi it's called thali. And when we showed different images of veggies and everything, people were like, but how do we make sure how much quantity of what we should have? And as after those co-creation and after that them giving us those feedback, they were like, it will be helpful for us if you show this visual in our own dish format, a dish that we can sit at home and look into. Okay, this much of pulses we should have, this much of veggies we should have. And that's where we created this thali model, which is also utilized with all the government hospitals in India. Yeah.
Okay, great stuff. Thank you for that. Um, Apart from co-creating, what kind of feedback loops are you in place to continuously improve the tool based on caregiver experience?
So we have the entire monitoring and evaluation team in place, with support of Stanford research team and couple of others external research team as well, who does baseline data. And after, once the care companion program is launched out, every 6 months the data comes up with teletrainers, not teletrainers, but then telecommunication, and also going in the field and observing the sessions, how they are happening. And we receive quarterly or in 6 months all those data to basically look back at what we have created, what's the impact of it, and which are the areas that needs to be redesigned or re-looked at.
Thank you for that answer. We have one more from Elizabeth.
Mhm.
Um, have you had clinical success to gain provider support? Um, Versus sepsis numbers and emergency visits post-op?
So our data and impact definitely shows that the readmissions have decreased. So emergency visits have definitely decreased. Specifically to, can I look back on the question?
Sure, you
I
can.
think it,
Um,
I think it went away, but yes, lower sepsis. So specifically in clinical setting is not where we work. It's more in the wards or post treatment when they are waiting, or the waiting areas where the caregivers are. These are skill based sessions, so our impacts are more based on those. But yes, emergency visits and readmissions is something that we have definitely noticed has decreased by a certain percentage.